everybody. I'm Susan Clinton, and I'm here with Erica Mello, and we're doing the intro to our Tough to Treat podcast this week, podcast number 76.
Yes, my gosh, 76. I know we've asked you all to write, testimonials and reviews on iTunes or wherever you guys listen to podcasts, and we really appreciate it. So we're going to be brief. We're going to read 2 today and just choose a winner for our webinar that's coming out. So if you are listening to this and your name is called, please email us, myself at erica@ericamello.com, Susan at embody-pt.com. The first one is from CR Tree. I believe her name is Cindy. I love your teamwork. I started listening to this podcast before I took a class from Susan. She's every bit as thought-provoking and respectful in class as she is with Erica. Love your teamwork. I've listened to each of the podcasts more than once. They help me ask better questions, listen more deeply, and notice my own assumptions. You ladies are a breath of fresh air. I listened to the podcast more than once too, Cindy. Thank you so much for that review.
Yes, thank you.
That testimonial. And the next one is the last one by this handle is called Is It Dumb? That's this person's handle on iTunes. Great way to sharpen clinical reasoning. The hosts have a great flow of thought with each of their episodes. They take you through the eval process and reflect on why they asked certain questions and what they might suspect with certain answers. They then discuss their proposed treatment and how it went when implementing it with the patient. Student and current clinicians will find value in this show. I guarantee it. Thank you so much.
High praise. Wow. Thanks so much.
High praise. So,
yeah, that's great.
You guys are all winners in our book, to be honest. So we're going to pick the CR Tree. Cindy, I love your teamwork. So Cindy, if you are listening to this, please email us to claim your free webinar. And thank you again, everybody. This particular podcast is a Facebook Live that Susan and I did probably sometime in April of this year of 2020. And it was so popular, we decided to put it out as a podcast for the general public, if you're not on Facebook or not a member of our Facebook group. And even if you are and missed it, it was a fantastic Facebook Live. And we talked about foot progressions, right, Susan, on exercise progressions for the foot.
Right, and taking a look at the foot, how it works with the whole body, and just some general ways to really get in and kind of start bringing some functional stuff in with the foot involved in the whole kinetic chain.
Yes, and we were very specific on exercise progression. And even if your patient has pelvic girdle pain or back pain, and you find that the foot is the driver, we speak to specifics about how you would progress that type of patient. We hope you enjoy, and thank you again.
And we thought we'd talk about just what happens with the foot, but what do we see a lot clinically, and how do we progress it? Erica does things a little different than I do, as everyone knows, but there's no wrong way. It's just kind of like, what is, test, retest, what's making the patient better and getting better results for everybody.
Yeah. I know we just recorded one this morning, and I started out saying, we talked about the foot, but it ended up in a very different conversation. So really interesting. So that will come out next Thursday. So I can start briefly, Susan, and we'll kind of sort of see how it goes. And if anybody has questions, feel free to post in the group, or if you're watching this later, feel free to post under the video. Like when would you give somebody, foot progression? Obviously, if the source of the problem is their foot. Right. So even if the person has, pelvic girdle pain, like I have had a patient some years ago, she had pelvic girdle pain and the source was her foot. So that's when you would give foot progressions. Right. What I normally do is I start out with, somewhat easy. It depends on the patient, obviously. But if the person is not has poor control on the foot, I will, start off with doing basic seated heel raises. Like I'll do some heel, so forwards walking. I'll have them do, heel, toe, and then toe, heel as you're going forwards. I'll also give them backwards walking, just plain old, forefoot heel type of control work. That's what I usually start off with. And if people do that really well, I'll progress. Susan, you can chime in.
Yeah. Well, just to back up kind of before we even get to the foot is, when you think about pelvic girdle pain, you want to look at the whole kinetic chain for sure and kind of think about what's happening there. And if they're, where the load transfer problem may be coming from. And oftentimes I notice the foot is not powering through the kinetic chain the way it should. And like what Erica was talking about, we have to think about not only how do they cope with load transfer, but how do they actually move that load through? And the foot really is the propeller to move the body over and to push the pelvis and the trunk along. And if they're missing something or they're not coordinating, the muscles and activities to develop that rigid lever or that softer lever, depending upon what the load transfer needs, then we're going to have issues there. And sometimes it is as simple as breaking it down to what does the foot look like when we're actually, progressing forward in like stance or with walking or with beginning to squat or coming out of a squat or doing those things too. And oftentimes I think, I'm not sure with you, Erica, I see usually a couple of problems. One is the foot never softens. And the other one is it never gets rigid. I mean, that's really black and white, like my picture right now. But, there's a lot in between. And I think part of it is, are the muscles, working, is the movement system working to create that rotational shift through the midfoot, that subtalar joint, and, so that they can lock up and begin to accept weight, by the heel rising, or is it untwisting to allow, the softening and the cushioning and the weight acceptance, on the other end of the spectrum?
Yes, I totally agree. I mean, when patients, often tell me they have let's say they have a pelvic girdle pain or knee pain or back pain with walking, you're obviously going to think, okay, well, the foot has to be somewhat of a player, or at least that has to be in your differential. And it's very hard to assess someone's step forward. I mean, you can watch somebody in gait and to look at their feet. And I often have patients take very large steps to see if there's anything non-optimal with their gait when they take big steps. But generally, I tend to look at a squat a lot because it's a really good full body movement. Or I'll take a look at a single leg stance, although that's somewhat hard because when they stand on one leg, they have to really get their weight over, and you have to really finagle and finesse your vision and your hands for that. So with the squat, I often look for, as Susan said, I mean, you've got the fan at the bottom of the squat and the fold at the top of the squat. And sometimes I'll have patients go up into a little bit of a heel raise at the top, just to see what their control is in that fold. And more often than not, they have deficits in both the fan and the fold. And I always ask, especially if they have a problem with walking, what part of the gait cycle is it with? Let's say it's the right foot. Is it with the right foot forward or the right foot backwards? Is it the push off or is it the load acceptance, like you said, right? Anything else you want to chime in on there, or do you?
Yeah, actually, that's what makes the squat such a great exercise to look at. I think we need to add the other end of the foot in now too, as we do that weight acceptance, and the untwisting, if you will, of that midfoot, complex. There also needs to be, as Erica said, that fanning of the metatarsals. But along that line, what I see is people may soften the midfoot, but they still maintain that. I'm trying to figure out how to work my camera here. Being all curled up.
Yep.
So really being able to translate that out to where the toes are long and reaching forward, and that full weight acceptance piece, so that they're not staying all curled, because when the toes are staying curled, that, you can't soften the foot into that full kind of thing. And so that can be translated up the kinetic chain with poor shock attenuation. Yeah. So sometimes, like Erica was talking about, getting under the foot, you also want to kind of get under those toes and begin to see, first of all, passively, can they extend those toes, and to what extent, and then help them begin to start to do that. I think everybody wears shoes that are too short and too tight, and our toes get tight and curled, and that becomes a real issue when we're really looking at balance and those kinds of activities that we want to carry all the way up and down the kinetic chain in a good way.
Yeah, I 100% agree. I think a lot of times I often start at the rear foot, but a lot of people, their navicular, we call it, for PT terms, it's more externally rotated. It's that rigid midfoot. You cannot attenuate the shock. You can't push through that midfoot to go into effective push off. I often start at the rear foot, and because a lot of these people, myself included, because I've had multiple ankle sprains and multiple injuries, as most people know at this point. I'm so hypermobile, but I have often in the morning when I get up out of bed, I have a very rigid foot. I cannot push through. I'm walking on the outside of my foot. And that's very, very common. And a lot of times those patients, it will translate up, especially into the hip. You'll see a lot of that, and also up into the pelvis. But it's important to find out what part of the foot is exhibiting this non-optimal movement. Is it the rear foot, the midfoot, the forefoot? Sometimes in standing, I'll lift the big toe up to see if I can actually lift it up. I mean, you really want the foot to be splayed on the ground. Like, imagine your foot is rooted to the ground, right, Susan? Yeah. So that's how I'm not going to go into the whole biomechanics of how we assess the foot. I mean, it's pretty somewhat straightforward, but I think it's so important, especially even if the patient, because the podcast we just recorded has knee pain on their opposite foot, for example, how is that person going to load? For years and years, you've had people offloading. Let's say they have right knee pain, right? They're going to offload that right leg and stand on that left leg for a while, normal. But over time, it becomes more of a habit. And that right foot will not get the load it needs. It's
right.
Right? So continue, Susan.
And the left foot will actually overload on the outside.
Yeah.
So I see that quite a bit. I see that, when you're looking at people and we're talking, this is really turning into load transfer, but when you're looking at people and you're really looking at how they're coping with load transfer and shifting, I notice that a lot of times they actually line up better on their affected side than on the other side because of that offloading for so long.
Right.
They really shift over there and stay over there, and it becomes, a habit, and they build a movement strategy around that. And now we've got a movement strategy habit that's a little bit tougher to change, without some mindfulness and some attention, onto the detail. And so then you end up with, which foot do you treat?
Right.
Do we treat the knee, or do we treat the foot over here that, and leg that has been offloaded so long? Or do we simply, where do we find the driver? And oftentimes you'll find the driver for that offloading really happening at the foot. And as soon as you can get the foot to change, you'll notice that the whole body quits offloading so much. It's just learning a new place of where balance is in their body and what's been created around that new movement strategy to offload that other knee.
Yeah, for sure. I mean, if you've had a chronic issue for years, or your patients, you're gonna offload that painful side. But at the end of the day, the opposite side is going to become so rigid and it's not going to be able to accept the weight. You often end up treating their opposite foot, because if you want to train, weight shift back and forth, you need to look at that foot. It's so important, especially for people who've had multiple injuries. They will, as human beings, we're often to one side, but I have found in my clinical practice a very strong correlation between side of symptoms and the opposite foot. Very, very strong correlation, actually.
Right. So what's your 3 best foot exercises?
3. I'm only limited to 3.
You get to pick 3 of your top.
Okay. Do they have to be beginning, intermediate, hard, or?
Nope, just 3 of your top. What do you like to go to first? If you're going to go put your hands on a foot, let's say the foot is rigid.
Okay.
You're not doing weight acceptance well. When you first go to the foot, where do you put your hands?
The rear foot.
Okay.
Subtalar joint.
And, okay, the subtalar joint, and you're working to get them to untwist that subtalar joint, right?
Right. So they're in sitting on the plinth. I'm on the stool. I'm doing a lot more in sitting, and I'm actually trying to feel where the muscle vectors are, because they have a rigid foot. Is it because they have muscles that are gripping, or is it just a strategy? Is it like a motor control issue, or do they actually need release of the intrinsics or of their FHL or of their calf? So that I will go there and assess the foot first, and I will release what I need to get released and mobilize what needs to get mobilized. It's more release. And then I will tape sometimes. We talked about this on the podcast. So that's the first thing I would assess. I'm not going to give someone an exercise if I have to figure out what's driving that foot.
Yep.
And then the next thing I would do, depending on, because often when you release something and they stand up, it looks vastly different. But depending on their task, what I will start off with is, because we know it's plantar flexion, dorsiflexion, inversion, knee inversion. I think we often forget the inversion and eversion part. And sometimes I will have patients do like a side lunge, or like a side to side, to see if they're actually, pronating and supinating in the appropriate way. Or I'll just have them stand and do a body twist and look at their feet to see if they're actually pronating and supinating, depending on the side that they're twisting towards. So I tend to go through the first phase very quickly. I do backwards walking a lot, because it's really mostly I have them walk backwards very slowly, toe heel. That's a go-to. So that would be one of the things I do. I give that fairly frequently. My second thing I'll do is more of an intermediate. I like these things called split squats. So I have them hold on to the wall, and they will start with their knees straight, and they'll do a heel raise. At the top of the heel raise, they'll bend their knees, and they'll slowly lower the heels with the knees bent. Now their knees are bent, they raise their heels. The top of the heel raise, they straighten, and then they lower down. So it's basically, knees extended, knees flexed, but you're going heels up, straight, bend your knees, lower down. Knees are bent, raise your heels, go up and lower down. That's a very common one I'll do. And then the last one, which I love, I really like to do lateral lunges, and the lateral lunges on a Bosu ball, because I think that really trains foot control. But I give, depending on the person and depending how much time they have, that's what I would go to. Of the three phases of exercises, depending on if they have a secondary something or other, maybe I'll have them hold a TheraBand, like a yellow TheraBand, and hold it taut, and they'll do some little mini heel raises, because that'll give thoracic control. But that's another podcast, another live. But those are my three. How about you?
So I would have to agree with you on the twisting. That's usually the very first thing that I do with people, is look to see where their transverse plane motion is being affected the most through the kinetic chain, and really look at the feet and see what the feet are doing and how they're coping with that. Then I actually take them, instead of doing side lunges. I love the foot progression you were talking about on the wall. That's something that I think people who have done Pilates are very familiar with, along on the Pilates bar on the reformer.
Yeah,
I'm working many kinds of things like that, which are really good. I like to do, I'll stay a little bit more low level, because you kind of got into some high level stuff, but hands on the wall the same way. And that's where I do the load transfer from one foot to the other. So I just have them lift their knee up and really just check and see what's happening. How much are they offloading? When they have their fingertips on the wall, they can't do the thorax rotation. So it takes the thorax out of it. And then you really see where the struggle is in the lower quarter.
Yeah.
So I like that, because I can get under their foot and give them cues to see how they can begin to start to clean that up pretty fast. And then the thing that I take them to, rather than going to the side lunges, which I do as a little bit higher level, but before we ever get to side lunges or Bosu ball side lunges and things like that, or even glides, sliding side to side, I like to do braided walking. And so, for instance, if it's the left foot that they've offloaded on, and so they're really hanging out on the outside border of their left foot, I will concentrate on the part where they have to actually pronate in order to step the right leg out. So I like them to start with the right leg over and really work that foot as the right leg comes out into abduction, to be sure that they're really, so it's a lunge, but it's a slowed down lunge.
Yeah.
And you kind of work in that direction more. So then they cross over, they still land on the lateral border of their foot, but immediately they have to start putting that foot down flat in order to uncross. So I like going in that direction.
That's good.
The direction opposite of the leg that's been offloaded on so long.
Yeah.
And, you know, so I'll just look at the foot mechanics that way and try to build it in functionally so that they have, and they can even just do that in standing, holding on to something, you know, step over, step out, step over, step out, and really, but the focus is on what the foot underneath is doing. I kind of tell them that, you know, your foot is actually driving the motion, you know, like the engine down below. So if the foot doesn't do it, this can't come out.
Right.
You know, your leg can't come out. So only as your foot begins to move does your leg go out, you know, and so that they can begin to get that piece of it in that load transfer kind of idea. And so those are the things that I like to work on as well. I think taping is great. I think it's great sensory input. It doesn't hold anything in place, as we all know. Okay. But Erica, maybe you could, when you say you tape the foot when they're not going into good weight acceptance, which way do you tape them?
Yeah, good. I sorry about that. I was just, there were comments and I couldn't see it. So what I do normally is, Susan, if you can see the comments, just, you know, answering. I can't see them yet. So I learned this taping when I took the Discover Physio series with LJ Lee and Diane Lee in 2012. And it's a medial calcaneal distraction taping where I basically, if I find that the medial part of the subtalar joint, a lot of it, many times it's inverted. And what I'll do is I'll take a piece of hypofix, very short, and I'm sitting, they're sitting off the plinth, I'm sitting on the stool. I'm literally taking the piece of hypofix, distracting it down, then I just let go because I don't want to twist the foot. I just want to distract it. And then I just I just take the other piece of the hypofix and go up the other side. It's very small. You know, it's not that much at all. It's this much. And then I'll take the Leukotape and do the same thing.
Yeah,
so
you're basically trying to just take the rear foot and twist it backwards. Twist it out of inversion.
Correct.
Yep.
Correct. And I would agree with you. I think that you know, what I often find as well is I take people into, we talked about this earlier on the podcast this morning, narrow base of support squats versus wider base of support squats. Someone who's got a foot issue is going to be able to compensate very well with a wider base. You know, try having somebody who's got a rigid foot do a narrow squat. It's very hard to do. Yep. And you will absolutely see a weight shift over to the opposite side. You'll see them in the mirror, then one knee will be further forward than the other. So I think that's really important. And I agree. I think that I like the backwards. I like the braiding. That's a good one. I don't do that. And I think that's good because that adds a little bit of the inversion eversion, the four planes of movement. I do like that. And so for me, I tend to progress. I mean, people like the backwards walking. It's so not functional, but I always say to them, it is sort of is functional because you need to be able to learn how to disassociate parts of your foot. And even if you're not walking and placing down, you're not going through this push off, you do need to have some control in movement throughout many movement patterns in your foot. And so I'll do really, depending if the person's post-operatively or depending if they've had, you know, if they have an acute foot. I don't tend to see acute feet very much. It's more the persistent ones. I will just take a look at how they walk forward, literally going, just place your heel down and then go through your toe and then step 2, heel to toe. And then I'll have them place their toe, like their forefoot, and then drop their heel, then step 2, and then their forefoot and their heel, just to see what it looks like. I don't necessarily give that out. But I do look at that if I believe that the foot is like the main driver. And, you know, I like the rotational part of the braiding. I also will give star lunges, you know, the star lunges that we have. Those are actually, you know, a bit easier than lateral lunges because you don't have that translational component. And I do tend to give that out depending on what the person's goals are. I'll give that out fairly often, especially if the person's a runner.
Yeah.
Anything else, Susan? I'm just going to see if I can take a look at the comments. I can't see.
So the only other things that I would say is when you want to go differentiate between if it's a rigidity or a tightness in the foot that's being held by the musculoskeletal system and not really due to a joint problem. One of my favorite tricks to do is everybody's got their shoes off, but one of the things that I'll do is I'll have them move, and then it's just really kind of an easy thing to do, but I'll grab their hand, because what the hand is doing, the feet are doing. So if it's run by in other words, if it's a neuromuscular system that's like upticked, like a lot of times people in pain, they'll be rigid because the muscles are over recruiting. And when that happens, generally the hand muscles are over recruiting too. I've really seen that. Yeah. So that usually can kind of tell me that, okay, we've got a component of over recruitment here. And for those of you who do pelvic girdle work or pelvic health work, or we all do pelvic health work, right? That's if the feet are being held, if they're over recruiting in their feet. I don't have any research to back this up. It's only clinical. Observation on my part, but I haven't seen a foot that's being held rigid that the pelvic floor isn't being held tight to.
Sorry.
That's okay.
I'm trying to get these comments in my phone. I have the volume all the way down. It's like, oh, hi, Teresa. Hi, Colleen. Hi, Annie. Oh, my God. We'll get this right one time. Okay, yeah. I'm with you.
Anyway, so that's some good stuff on the foot for everybody.
Yeah, it is. I mean, I think I just would like to, let me see how much time. Just looking at the time. A couple of other things that I just would want to mention with regards to the foot. I think that, I had a patient a while ago, probably a couple of months ago. She was a tennis player and she had issues with her neck. So she had a lot of problems just doing a push-up, and she really wanted to go into a push-up. And in order to do that, you have to be able to put your feet on the ground and you have to load your foot. So even if the person wants to be able to do a push-up, they do load their feet and they will offload. So when she went into a push-up on the wall, she literally was all the way to the left, okay? And we had her do a narrow base squat. She couldn't dorsiflex her right foot. So right foot wasn't in her complaint history. It was in her injury history. So when I actually got her sort of centered, her right foot could not take the load. It could not dorsiflex, even in a push-up position on the wall. So when I had her go onto the floor, she still couldn't, because you have to have that foot dorsiflex. She was all the way over to the left. So what became a basic sort of neck, upper thorax driver for her push-up, she had a secondary issue in her right foot because of an old injury. And if I did not treat that right foot, she would not have gotten 100% better. And so, yes, you need to treat the primary issue first, but you would still use these foot progressions because the foot is in the picture. Do you have to take them, through, heel toe, backwards walking, split squat, star lunges, heel raises? No, you don't have to. It has to be pertinent to their presentation. So, the only other thing that I would look at, especially, with somebody like that, is, even if they have an upper extremity issue and their foot is the driver, you still need to incorporate upper extremity activities within the foot program. So you would do like maybe a bilateral arm lift on like a Bosu or on a rocker board, or have them, you can cue your, the foot. I always have patients like, imagine your foot's rooted to the ground, or splay your foot. I don't know what types of cues you use, Susan, but it depends. And I will do that. And I will have them do upper body movement, depending on what their main issue is. Even if the foot is secondary, the foot's primary, you're going to take them through a major foot progression. And I could put these in the comments as well, what I would do. But I think that even if the foot is secondary, you need to incorporate some of these foot progressions in them. But because people don't have a ton of time to do 50 exercises, our best advice is really just, incorporate full body, closed kinetic chain, lower extremity with some open chain upper, squat with an arm lift with a ball, or have them squat and do rotation, squat with heel raise rotation. Anything else to add, Susan, on that? I mean, I could go on forever, but
the biggest thing that I do is I just add the rotation in, because I really want that balance system back as much as possible. Because if they have a foot that's behaving, you know, or if they have, you know, because they have this motor pattern, this motor habit, that really drives the entire balance system, I think, over time. So I do a lot of that stuff as well, but I incorporate a lot of head turns and, you know, moving heads and stuff. So even in single leg stance with their fingertips on the wall, the first thing I do is I'll have them start turning their head to look and see how they can cope with that, because that can drive a lot of rotation through the system. And generally that's where they're falling, you know, that piece is missing, you know, quite a bit sometimes on people. So power is important, mobility is important, but also neuromuscular re-education, balance systems approach is important as well. And I think that's kind of the take home here, is that the foot is the foot, and it's important to address it, but it's important to address it within the context of the entire human body, the human movement experience.
Yeah, no, I agree 100%. And I think you just need to, it's patient dependent, but, you know, for those of you who want, you know, like lists of things to do, I mean, I can put some, you know, I can just put something in the comments below. It'd be really easy to do, and I'll do that right after, because I have a list of things I wrote down, and I'm happy to do that, because I do think sometimes people need to see the list. But you need to absolutely, because the kind of patients that we see are not, you know, they're sort of complex. You know, they've got 5 body parts that hurt, and the longer you have the problem, there's going to be more than one driver. So you have to incorporate that secondary driver. If it's not the foot, if the primary is the foot, or if the secondary is the foot, you need to incorporate full body movement. If heel raises isn't going to cut it, it's just not going to cut it. You need to do a little bit more full body movement, bearing in mind what their problem is. Is it the fanning? Is it the folding? Is it the load transfer and gait? Is it the push off? Based on what they're presenting with, you can design a really clean foot progression, and they will get better. You know, and the key, as Susan said, is just incorporating it with full body movement. And I think that's the take home here. You know, I'll put the comments below. I'll put the foot progression. But I do think that because we see so many complex patients, they're going to have more than one problem. So you need to incorporate arms. You know, we talked about the podcast this morning, you know, head movement is so important. There's a really strong connection between the head and the foot, as we're finding in our next podcast 68. You will find out. Okay. Does anybody else have any questions? I can't see the comments, but I'm not. This is our first one, so we just wanted to see how this goes. I don't. Susan, can you see Facebook? Can you see?
I can see. I don't see any comments as far as questions go.
Okay, got it. Okay, so I'll put the comments in below some of the foot progressions that I talked about. Okie doke.
Sounds great,
everybody. Thank you for comments or questions. Let us know if you want to hear other ones, different topics. Just let us know in the comments. Thanks. Bye.
Bye.